So good morning. Without much delay, I think we'll go on to the next instruction course, which is Pediatric Ocular Trauma, Eternal Conundrums. So I would request Dr. Muralidhar R and Professor C.V. Radha Devi to come and chair the session. Please. I would request Dr. Saumya Nambiar, consultant pediatric ophthalmologist from Comtrust Eye Hospital, to give her talk on corneal injuries in pediatric patients, do's and don'ts. Over to you, Doctor.
Good morning, all. First of all, I would like to thank KSOS and Dr. Lakshmi for having given me this opportunity. So, corneal injuries in adults, as such, is a challenge, and pediatric corneal injuries is furthermore. So, let's see how do we manage. I'm going to talk.
Have a bit of silence, please.
I'm going to talk regarding my presentation under the following headings. So what is the, why do you need to know about pediatric corneal injury? First of all, in a pediatric corneal injury, identify which type of corneal injury it is.
It would be greatly appreciated if you
identify the problems which are seen in the pediatric age group, and what are the main do's and don'ts that we have to think as a general ophthalmologist in managing a pediatric corneal trauma. So when you see that whenever a child comes with pediatric trauma, we know that the most common, it's one of the leading cause of non-congenital monocular blindness in children. And eye trauma constitutes 7% of all bodily injuries and 10 to 15% of all eye diseases. And this is the incidence which you see, and you can see that India is somewhere in this range. And this was a paper which was seen in conducted in a tertiary eye care in central India. And as you can see that among the pediatric trauma cases, most of it were the males that were, the boys were more commonly involved, and the lower socioeconomic group was more involved with injuries. Till now, an adult ocular trauma score by Kun et al. Was being followed. So as you can see that each of the trauma like visual acuity, globe rupture, endophthalmitis have been given certain points. But a pediatric trauma score was not there up till last few months and few years. And the problem with pediatric trauma is that you cannot check the visual acuity in a child as you can check in an adult. Plus, in condition like an RAPD, which you can do it in an adult, it's not easy to check in a child. So that was the importance why a pediatric ocular trauma score came up. And as you can see that all the points that have been given, can I have a pointer, please? The points that have been given, as you can see on the right-hand side, the points are reduced when compared. Yeah, you can see these points. Their raw points are reduced for the pediatric cases, okay? And higher the points, it is presumed to have a better prognosis. And you can see that here, age is given a criteria, not like the adults. That's because in adults, as I told, visual acuity is given importance, RAPD is given, but in pediatric cases, you have to look at the age, and that determines. The lesser the age, the prognosis may be bad. Now, when you're dealing with corneal injuries per se, what you have to know is that these could be a closed globe injury, it could be an open globe injury. The simple corneal epithelial defect, a corneal aberration, a corneal chemical injury, a lamellar corneal tear if it is partial, or a full thickness lamellar tear or full thickness corneal tear can be there. So problem with a pediatric patient is one of the things is that it's difficult to examine the children, and you may not get a proper history, okay? And therefore, you need to have a very keen observation. Like as you can see in this child, the child has a very low blink rate. So you know that there's some problem that is going on. And as you see, the child is crying, and you can see the child is actually having a facial nerve palsy, okay? So such children, when the blink rate is less, there's a chance of foreign body injury, the response may be a little bit less. So in pediatric cases, the thing that you should remember is a small infection can progress fast, and therefore you need to act fast. A delay in diagnosis increases the risk of endophthalmitis, and because the pediatric eye is a developing eye, the chances of amblyopia is even more higher, and the need for general anesthesia, though that is one of the factors which will cause a problem for giving a first-hand treatment. And as a primary care physician, what you have to remember is that as a child walks into your clinic, you have to take a thorough history, because through history itself, you can gauge that probably this child is having a penetrating injury, or maybe the child is having just a epithelial defect or a foreign body. And you have to ask where this incident has occurred. And any medical legal issues, like battered baby also can be there. You may not get the history in the initial stages, but later on it may come, and you have to see that you have documented everything. And remember to observe, like supposedly there is watering, there's difficulty in opening eyes. You have to think why, and then look and hunt for it, okay? So I'll be dealing with each of these in this way. First is a corneal foreign body, which is the most common way that they can present. Remember, in a pediatric case, or for that matter, any foreign body, you have to do an eversion and a double eversion. And if it is a superficial foreign body, if it is in the palpable conjunctiva, definitely you can remove it even if it is a kid. But if it is deep, you may have a rust ring associated with it. You may need a scraping. That time you may need a anesthesia for the kid. Look out for vascularization, especially if it is an old foreign body. This is very common in children, and sometimes infiltration also can be there. So you may need to examine the child under microscope, under a sedation maybe at least. The second scenario is a chemical injury. It could be acidic or alkali, and alkali is the most common. And as we do, usually you give at least a 30-minute wash till the pH is altered. But remember to remove all the particulate matter from the fornices, avoid the conjunctiva, remove the particulate matter below the palpable conjunctiva as well. And remember that tap water is found to be more hypotonic and may tend to increase corneal edema. So if you have BSS, that is more preferred. The third thing is corneal aberration. So whenever you have aberration, you have to rule out penetrating injury and then only stain the cornea. And you can see, depending upon the stain, you can localize if there is any foreign body also, okay? And if it is taking up the stain or not. And as I told, stain only after ruling out penetrating injuries, okay? Then as corneal penetrating injury. Now it could be a full thickness with foreign body or without foreign body. And if preoperatively, whenever you get a penetrating injury, history-wise, history is very important. If at all there is a history of a high velocity traumatic injury, always suspect a penetrating injury, even if you're not able to examine the child. And if doubtful that it is a full thickness, only if you are doubtful that it is not gone full thickness, only then do a Seidl's test. You can do a full Seidl test to see if it is negative or positive. And whenever you find a foreign body, do not attempt to remove the object. And any subconjunctival hemorrhage, you need to explore and see for any extraocular muscle or scleral tear. And as a general ophthalmologist, always tell the child to be on NPO, start systemic antibiotics, give a GVP, and explain that they may need more than one surgery. And always record whatever you have done. And the goal of corneal surgery is same, tight sutures. These are the videos which Laila madam has given. You have to take a culture from the wound site, remove the exudates overlying it. Always look for other injuries. You may miss out all these, okay? So open the conjunctiva in the corresponding area and look for the tear. And use lot of viscose and see that the iris is not adherent to the site of your wound. And if at all possible, do a paracentesis and from that site release the iris. Always bury the suture. Do not leave anything unburied. At the end of it, do a Seidl's and confirm that it is tight. And if possible, take a IOL calculation, do a fundus examination also, okay? And in the late stages, look for the suture strength, do IOP monitoring, look for vascularization, and definitely do a amblyopia treatment. And always prevention is better. Get an ocularist opinion, and especially in a one-eyed children, you have to wear protective glasses. Tell the parents about it and educate them about it. Thank you.
Thank you, Dr. Soumya, for the extensive coverage. And I next call upon Dr. Vidya N to give her talk on pediatric lid and adnexal injuries. Dr. Vidya is a senior consultant in Eye Foundation, Coimbatore, in oculoplasty.
Very good morning, and thank you, Lakshmi, for having me here. So I'm going to be talking about eyelid and canalicular tear management. We all know that ocular adnexial injury is the most common scenario that we get to face in our day-to-day practice, and it's important that we know the principles very well, because it's not just repairing this lid tear, it is to prevent all this lid notching, exposure keratopathy. We need to prevent ocular surface disruption, and we also need to address the aesthetic concerns of the patient, and we need to prevent the functional problems like canalicular stenosis and epiphora. The basic principles remains the same. We need to have a very clear-cut history, very careful examination, and we need to prioritize our treatment depending upon the presenting condition of the patient. So the detailed history should include the mode of injury. We need to be aware of the penetrating injuries can lead to all intraocular and intraorbital foreign bodies. Dog bite requires a different level of management, so we need to be aware of that. Physical confrontation has got medico-legal aspects, so we need to note down in our history. And injury with hooks, which is especially more common in our area, has got the propensity for causing canalicular tear, so that we need to remember. So I talked about the medico-legal aspects. I'll also cover it in the subsequent slides. And we need to be knowing about the time since last feed, because most of these cases we would operate under general anesthesia or IV sedation. So the ocular examination should include globe integrity. We need to be sure of that. And we need to record our vision and color vision wherever possible. And pupillary reaction, we need to be specifically looking for RAPD. Extraocular muscle and the motility problems we need to be aware of, because some of these penetrating trauma will also be including fractures, and radiology wherever indicated, specifically to rule out foreign bodies, and preferably all these cases should have preoperative photographs as well. So the management will differ with full thickness or partial thickness tear, or sometimes the marginal involvement will have a different line of management. Specifically, we need to be aware of this medial canthal injury, which is medial to the punctum. We need to rule out canalicular tear, either with direct observation or by doing a probing. One clinical tip would be a laterally displaced wound with distorted medial canthal area usually has got canalicular involvement. So the indications for imaging, we'll do that whenever we suspect an intraocular or intraorbital foreign body, or when we suspect a fracture, or when there is an optic nerve avulsion or suspected intracranial injury. The modalities we have ultrasound, CT or MRI. I would prefer CT because it's quick, it identifies the fractures, and it is also less financial implication for our patients. Documentation, as I mentioned earlier, clinical photograph is a must, and we need to have explicit documentation about vision in the eyes. Whenever we say about documented or guarded nil visual prognosis, definitely we need to document that. And we also should mention about the possible need for repeat surgery or intervention. Some of these cases might require some revision or exploration. And in case of head injury, the priority is attending to the patient's general condition first. If you have a coexistent globe rupture, it is globe rupture first, followed by lid tear repair. Anesthesia, majority of these cases in adult can be done under local anesthesia, in which case we would prefer an infraorbital and infratrochlear block. But in children or extensive injuries where we require longer time to repair may preferably be done under general anesthesia or IV sedation. So I'm going to be sharing top 10 points that we need to keep in our mind whenever we deal with these kind of cases. Number one is a thorough wound inspection. We need to look for foreign bodies like this. So some of these foreign bodies may be embedded in the site of injury itself. So that has to be explored and taken out. And some of these tissues may appear a little necrotic, but we don't have to excise the excess tissue. We don't have to debride it, because apparently avascular or necrotic appearing tissues will usually heal well, because lid is a very vascular structure. Lid tear marginal repair has got a specific technique, which is far near pass technique. We go 3 millimeters from the cut edge of the wound, 3 millimeters down, and we reverse our needle and come back 1 millimeter from either side of the wound, and then we suture the knot. And we need to be specific that this wound edge, when we finish our suturing, it should be everted, and we leave the suture knot a little longer, and we take it in our subsequent sutures. So that is the technique for lid tear marginal repair. And lid tear not involving the margin can be repaired as we do suturing in elsewhere in our body. So like a skin muscle flap can be sutured the same way we suture our lid tear, not involving the lid margin. Canalicular injury, the critical factors here would be how extensive is the injury, whether it is proximal or distal. The coexisting lid abnormalities and ocular abnormalities will make it decide on our anesthesia part of it. And specifically for the canaliculars, one or both canalicular involvement we need to take up, and also the choice of stent that we are going to use it. So here's a short video on canalicular repair. The initial step is a punctal dilatation, and then we use a probe, a lacrimal probe, which will pass through this cut end of the canaliculus. So when we pass, we could identify the pale pink structure here. So that is the cut edge of the canaliculus. Usually if we use a higher magnification, that helps in identifying the cut edge of the canaliculus, or sometimes you can use adrenaline drops also to have vasoconstriction. So here I'm using an oro stent, which is a monocanalicular stent. This stent has got a small collar and stud here. So this will go and sit in the punctal area. So just pull it from the other edge. One tip here would be to use a non-toothed forceps and not to hold the tissues with the toothed forceps, because that tends to crush the tissue. So pull the monocanalicular stent, and usually in adults, because the punctum is little patulous, it goes out when we use a punctal dilator. But with the kids, it doesn't happen usually. So you need to pull from the other side. So that makes it little tricky here, because if it is close to the punctum, then it is a problem. So for want of time, I'll skip this rest of the part. So usually we finish it with the peripunctal canalicular thing. A stent removal is very easy. Just do it in the OPD with the non-tooth forceps. You can pull out the entire stent in one go. So this is how we remove the stent. Usually we keep it for about 6 weeks. So periorbital fat, if it is there like this, it indicates that there is violation of the orbital septum. If it is in the upper eyelid, we should expect that there is an LPS involvement. So, and we need to repair it in the first go itself. And when we suture, we should take care not to suture the orbital septum. It may result in restrictive retraction like this. And sometimes patients do present with irregular apposition, which may require reconstruction. This particular patient, we have done a Z-plasty, and this is how he looks post-operative. Lid tears following dog bite requires a special mention, because this is more common in kids. We have to copiously irrigate the wound area. Rabies and tetanus prophylaxis to be observed, and infiltrate with the local immunoglobulins. 24 or to 48 hours, we can do the primary repair. And systemic antibiotics are usually indicated because this is a polymicrobial infection sometimes. So we need to remember the complications, many of it I've told, and meticulous repairs usually give excellent results like this. Thank you so much.
Thank you, Dr. Vidya. And next, I would call upon Dr. Muralidhar, Senior Pediatric Ophthalmologist, Glaucoma Consultant and Neuro-Ophthalmologist in Eye Foundation, Coimbatore, for his talk on pearls in the management of extraocular muscle injury in pediatric population.
Okay, sincerely thank KSOS and Dr. Lakshmi for this wonderful invitation. Okay, so I'll be talking on pearls in the management of pediatric extraocular muscle injury. Mouse fell upon me. Mouse is not working. Okay, so I'll first start with a flap tear. A flap tear is essentially a part of the muscle getting injured. Either you could have one layer. You know that an extraocular muscle has got two layers. One is an orbital layer and the other is a global layer. So one of this could be injured, or the muscle, a segment of it could be injured, and only a thin part could remain there, and could be associated with orbital fractures. So these are the various possibilities. So the history is all important in extraocular muscle direct injury. So this child developed this strabismus when she was traveling in a bullock cart. She got injured by a hook that is used to suspend the lanterns. So if you see here, this is the intraoperative photograph. So there is a scar here. The extraocular muscle has been avulsed. Avulsion is actually an old term. So the lateral rectus could not be retrieved. It was exposed till the inferior oblique. So what we did was we did a half tendon transfer with Brooks modification and Foster's modification, the Hamilton's transposition of both the inferior as well as the superior rectus. So once we did that, so that is the superior rectus. So you have to free the superior oblique before you detach the superior rectus. So the superior rectus is split and half tendon of it. I usually resect 3 to 4 millimeter and then use a Foster's modification also. And so it is sutured to the area of the lateral rectus. Now you have other options like the Nishidas, but I still prefer this double augmented suture that was published by Shetty, Shashikant Shetty et al. So after doing the Foster's modification, you have this is the preoperative photograph and this is the postoperative photograph. So some of the adult photographs are also there. The principles are largely the same. So this is a Bulgur injury. So the inferior rectus got avulsed at the insertion, couldn't be retrieved either. So an inferior oblique total antro positioning was done. So you could, you note here the inferior rectus actually could be hooked, but the inferior rectus was torn quite behind the equator, somewhere close to the optic nerve. So we couldn't explore till there. So we did an inferior oblique total antro positioning. And this was another patient where the inferior rectus got avulsed. He braked suddenly. He was traveling in a two-wheeler, and the bag hook used to suspend his luggage hit him, and the muscle was avulsed. But here we were luckier. So here we were luckier that the inferior rectus could be retrieved, and we managed to restore the alignment. Note the inferior, the globe is left globe is hypertropic, and after retrieval, we could restore the ocular alignment with full ocular motility. So this was another condition. This is also a sharp injury to the globe. So you can see actually the muscle hanging out. So this patient had a different condition in which the orbital layer was avulsed. This is a true flap tear. So as reported by Raab et al., we excised the orbital flap. We couldn't retrieve the proximal portion, so we excised the orbital flap, which was acting as a hindering portion, restricting the depression here. And we managed to restore ocular alignment. The right globe is hypertropic here, and we have restored the ocular alignment. The right eye depression is restricted, and we have restored the full ocular motility just by excising the orbital layer, so which was acting as a hindering layer. This is a flap tear of the orbit. So on MRI you can note that the there is a fine line here which represents the site of injury. The orbital layer has got detached from the global layer and it was hanging out. So we just excised, it was acting as a hindering layer. So this is, I'm sorry, this is again a post-sinus surgery. So in primary position there is a exotropia, and the right depression is restricted as also the right elevation. And we got the CT scan. This is the Hess charting showing showing restriction of adduction and depression. And so actually there is violation of the fat plane between the two muscles. The inferior and the medial rectus have got adhered to each other much behind. They have almost fused together. So you can try separating it, but the prognosis to restoration of ocular motility is not very great. So this was again a road traffic accident with avulsion of multiple extraocular muscles. So the medial rectus had got avulsed, as has the superior rectus also. So we managed to retrieve the medial rectus and suture it. Superior rectus could not be retrieved, so we just did a partial tenotomy of the superior oblique. We managed to restore the horizontal ocular alignment in this patient. So it was a PL negative, so there was no double vision. So now come to blunt orbital trauma, specifically in children. There is paucity of literature, and there is not a great consensus on managing this category. And it is a multi-speciality coordination that is involved in managing. They are not young adults essentially, because the extent of facial growth and development, I'll be covering this in the slides to come. So if you see the skull to face ratio in childhood is 8:1. The skull is much more prominent. This becomes 2.5:1 in adulthood. So sinuses are not well developed. So the sinuses which could actually absorb the impact force are not very well developed. So the pattern of injury is different. The direct extraocular muscle injury may be similar, but the pattern of the orbital fractures, they are quite different. You still get these blowout fractures in slightly older children. Usually they are trapdoor fracture and they are web off. That is white-eyed blowout fracture. The external signs of injury may be very less. So it's called VBOF, a white-eyed blowout fracture. I'll just be showing some. So these are the other presenting factors. You can have the oculocardiac reflex, you can have nausea, vomiting, and limitation induction. You really require some patience. So this child developed this head posture after injuring his eye, bumping his head on a flower pot. So this is day 1 after injury. If you see, there is hardly any, hardly any signs of orbital or ocular inflammation. So the right eye depression, if you see, it's subtly restricted. This is a very, very important sign because this guides you to the appropriate investigation. So this depression restriction is a very important sign here. So it doesn't improve on duction testing. You have the typical teardrop sign that you see in these orbital blowout fractures. And this was after repair of the fracture, the face turn went away. And you can see in these very young kids, so note very carefully, the depression is restricted. So you can see the right eye depression is restricted. This is a very important investigation. You have to be really patient here. So this shows you that you need to get a CT scan done for this kid. And this was another patient who actually sustained injury when she bumped her head against a wash basin. And if you see here, so a mesh was put, and subsequently for some reason the mesh was removed also. So the nerve to medial rectus has been injured in this. So you see this very important. The reason I put this adult here is it's important to recognize this because forced adduction testing may not be possible in children. So there is a floating saccade here, floating adduction saccade here, which tells you that the medial rectus is pyretic. So I'll wrap up with this because I'm running out of time and the oration has to commence. So if you see here, this is a left inferior oblique palsy, and this was the only case in which the cover test showed a small right hypertropia. We got a CT scan done, and if you see here the area of the inferior oblique, there is a blowout fracture. So conservative management because the muscle per se was not entrapped, and this is a patient with superior oblique palsy. I'll just forward the video. So very subtle superior oblique palsy. You can see the hypertropia here. So this subtle clinical sign, and you can see the orbital roof fracture and the superior oblique getting entrapped here. So I'll wrap up this thing. I have a couple of more slides, but I think in interest of time and for the other speakers, I'll wrap up.
Thank you, sir, for that extensive coverage. For want of time, otherwise we would have wanted to hear more. So next I call upon Dr. Neena R., Head of the Department of Pediatric Ophthalmology and Strabismus and Giridhar Eye Institute, to cover an important topic of traumatic optic neuropathy in children, when to suspect and how to manage.
Thank you, Lakshmi and KSOS for this opportunity. So I'm going to talk about traumatic optic neuropathy in children, when to suspect and how to manage. So we know that traumatic optic neuropathy is an acute injury of the optic nerve secondary to trauma. And just like in adults, TON in children is an important cause for poor vision and has poor has poor visual prognosis if you don't pick it up early and intervene. Because even if you intervene, some of them does seem to have very bad prognosis. So the signs would be the same as in adults. But children being less expressive, they don't often complain about defective vision and they won't be very expressive in their complaints. So we need to have a high index of suspicion to diagnose TON in children. So just like in adults, there would be vision loss, color vision loss, visual field defects. RAPD is an important sign. In cases of trauma, often we miss the pupils, and that may be the only sign which would be the definitive indicator of an optic nerve injury. And sometimes there would be orbital signs like fracture, resistance to retropulsion, retrobulbar hemorrhage, and proptosis may be there. So we can classify TON as direct and indirect TON. Direct TON is due to an anatomical disruption of the optic nerve, either due to a direct penetrating injury to the optic nerve or due to a compartment syndrome from an orbital hemorrhage or an optic nerve sheath hematoma. Indirect TON is due to a shearing injury to the intracanalicular portion of the optic nerve, either causing an axonal injury or an ischemia of the optic nerve. So causes can be multifactorial. So as early as Hippocrates, he was one of the first people to describe that traumatic optic neuropathy could be a complication of head injury, and blows to eyebrow may cause blindness, and this is called the Hippocrates sign. So if you have any patient who's walking into your OPD or who's brought with a scar which is involving the medial 2/3 and the lateral 1/3 of the eyebrow, there is a very high chance that the child or the person may be having a traumatic optic neuropathy. And the site of injury is usually the forehead or supraorbital ridge, and less commonly the temporal region. So this is an important, the blows to the eyebrow is an important cause of traumatic optic neuropathy. Now, there is an anatomical classification given in Walchenhoid's Neuroophthalmology. I thought I'll just put in for the sake of information. You can have depending on where the trauma to the optic nerve is. If it is to the nerve, it's visible to us as optic nerve avulsion or a hemorrhage to the optic nerve. If it is in the proximal portion of the optic nerve within 10 millimeter of the globe, it presents like an anterior traumatic optic neuropathy. It can present with either a CRVO or a CRAO-like picture or an anterior ischemic optic neuropathy like fundus picture. But if the injury is posterior to the entrance of the vessels, it presents as a posterior traumatic optic neuropathy with absolutely normal fundus, and you may pick up the pallor only after 4 to 6 weeks of onset of trauma. So these are some of the pictures. You can see the avulsion here in the first picture and a CRVO-like picture. So sometimes if you have a high index of suspicion and you can do a flash VEP, and they say that flash VEP amplitudes less than 50% of the normal are a prognostic, like they say that it's not likely to improve. So CT orbits is a very good tool to evaluate the orbit and the optic canal. So especially if you're suspecting a direct traumatic optic neuropathy, look for optic canal sections and look for any fractures or any crowding of the optic canal, and both look for the sagittal and the axial sections. So if you have a direct TON and with a compressive element, definitely there is an indication for decompression. Discuss with the neurosurgeons and do as required. So these are some radiographic pictures which I picked up from the American Journal of Neuroradiology. Beautifully, they're showing the complex facial fractures here with the fracture in the bone segments in the optic canal of the right side. And in this picture, you can see there is a medial orbital wall fracture, and if you see the optic nerve is stretched. Normally, the optic nerve is tortuous when you have it. See, this optic nerve is stretched, so that indicates there is trauma to the optic nerve. And in this picture, there is a fracture of the posterior orbital lateral wall, and you can see that the left canal is normal, but you can see there is a widening of the canal here. Soft tissue injuries can also produce traumatic optic neuropathy. Like here you have this hematoma, which is abutting the left optic nerve, and here there is bilateral injury, and you can see that here there is avulsion. The left is totally disorganized globe, but the right globe is also, there is avulsion, and the optic nerve head are thickened. And here is another picture showing the optic nerve sheath hematoma. So these pictures can be visible. So these are some other pictures that will tell you axonal injuries can be picked up on MRI. So I've already described this. So there is controversy regarding management of the optic nerve, traumatic optic neuropathy. But what we generally do is, if there is a direct traumatic optic neuropathy with a hematoma or a bone fracture impinging on it, you have to go and do a surgical intervention. Systemic corticosteroids is controversial, but we do give IV methylprednisolone if there is no traumatic brain injury. You have to discuss it with the neurosurgeon. There are conflicting reports. This case series, the prognosis was not very encouraging, whereas they found that surgical intervention in pediatric population did help to improve the vision in as much as 80 of their case series patients. So just a few cases. This is a case of optic nerve head avulsion. You can see the OCT and the B scan picks up these. And this was an injury with a bat, vitreous hemorrhage, and Berlin's edema was there. Vision was very bad, but there was RAPD, and VEP showed a prolonged latency, and we treated it with IVMP, and vision improved, though not much. Another patient who presented late, pale disc, history of fall 5 months back. Can't do much now because already the time is lost. So it's difficult to diagnose, high index of clinical suspicion. Give them the benefit of doubt, intervene when early, and prognosis usually is guarded if you don't suspect it early. Thank you very much.
Thank you, Dr. Neena, for that extensive coverage. So the next speaker, actually Dr. Tamilarasi, due to an emergency, she couldn't make it to the talk today. So I will be covering the two topics hereforth. So I would be presenting this topic on behalf of Dr. Tamilarasi. My sincere apologies. So this is IOL power calculation in pediatric population and how to go about in a traumatic cataract. So, pediatric traumatic cataract, we are posed with a lot of problems because it is not just like an adult injury, and open globe injuries are more common than closed globe. An initial evaluation, like all the speakers have mentioned, is very important. A posterior segment thorough evaluation to rule out any posterior segment significant pathology should be done at the initial visit itself as far as possible. And why is it so difficult to manage traumatic cataract in a pediatric age group? It is because there are a lot of changes in axial length and keratometry, especially that happens in the first 2 years of life. And children are quite uncooperative, especially when they undergo a trauma. There could be a lot of stress. The parents will be stressed. And different biometry and anatomical differences from adults are there, and we need to use adult formulas, and we'll have to adjust for the pediatric population. And cataract surgery itself is slightly different, and the effective lens power might change a little bit according to the lens placement. And target refraction is another problem that we face in the pediatric population. So it is just not we just calculate the power and put it, we have to anticipate a lot of things to take care of the growth. So axial length in the pediatric population, it increases more in the first 2 years of life, more so in the first 6 months. And immersion is better than contact biometry, but in most cases we may not be able to do so. And if needed, we need to do a general anesthesia before the surgical management. In traumatic cataracts, that also may not be possible. So an initial globe repair with a secondary IOL implantation might be considered. An optical biometry should be considered in any cooperative children, and if the injury is in such a way that we can do an optical biometry. This is a handheld keratometry done to get the keratometry readings of a small child, and this handheld keratometry can be done under anesthesia, or if the child is cooperative enough, without anesthesia. And keratometry in corneal tear, what are the points that we should take into consideration? We may not be able to take a correct keratometry reading in a corneal tear child, so we may need to take it from the contralateral eye. And the corneal curvature is slightly steeper in children, so it might be difficult to take a standard K. So we may need to calculate the other eye K reading and take it. IOL calculation formulas. This again is not same as in adults. The infant FAK treatment studies have shown that Holiday 1 and SRK-T give the minimum possible errors, but we generally use Barrett's Universal 2, which has given promising results. And we need to have a caution in children less than 2 years, age less than 9, axial length less than 19 millimeters, and a steep K. And in less than 2 years, we need to think a lot before placing an intraocular lens, because we have to take into consideration a lot of things. And less than 1 year, it would be judicious, if it's a traumatic cataract, to go in for a secondary intraocular lens if all situations are not favorable. And what about the target refraction? The eye is growing, so we can't put a lens and just forget it. So we need to calculate for the growth of the eye and the myopic shift. So what sort of target refraction do we do for pediatric cataracts? It's similar to the target refraction that we aim for in developmental cataracts. In general rule is 20% in less than 2 years and 10% in 2 to 5 years, but we need to tailor make each IOL power in each child. It might be different. Sometimes the axial length might be different. It may be the child might show a higher axial length or a shorter axial length. So we need to calculate for undercorrection basically, since we should expect a myopic shift. More than 6 to 8 years, we need not undercorrect. We can put the calculated intraocular lens power. So the factors affecting the time of traumatic cataract extraction, if there is a severely compromised anterior capsule and an intumescent lens, we need to do a cataract lens aspiration at the time of corneal tear repair, whereas we will wait maybe a few weeks before we plan for a secondary intraocular lens. So this is a video showing the traumatic corneal tear repair with a ruptured anterior lens capsule. The lens aspiration is done, followed by a posterior capsulorhexis, and this should be considered in every child less than 7 or 8 years of age, because the chances of posterior capsular opacification is great. But however, we need to tailor make our decision, because there might be some cases in which the posterior capsule might be compromised, or the zonules are compromised, in which we go with a different decision. So IOL in a traumatic cataract, which type of lens do you implant? We generally go with a single piece or a multi-piece acrylic intraocular lens in most of the cases. And in some cases, when there is compromised bag or a posterior capsule, we might go in for a secondary intraocular lens implantation. So what is the problem in putting a lens in the sulcus if there is a compromised posterior capsule? We need to take care of the anterior optic capture, which is very common in children in sulcus placed lenses. We can prevent this with a primary posterior capsular rhexis with a posterior optic capture in the posterior capsular rhexis. Or this is a technique which is described by Dr. Ken Nischal, the banded technique, in which the band which is formed in the anterior capsule, that is left behind, and this acts as a support to prevent lens iris contact. So that is another thing. And in some cases in which the anterior capsule is intact but the posterior capsule has ruptured, we can do a capture in the anterior capsule as well. Open globe injuries with compromised bags, cortical matter in the vitreous, we might do a globe repair first and then go ahead with a secondary scleral fixated IOL according to the age of the child. So what happens when we cannot do an A scan? We can go with a technique which has been described, that is, do an aphakic refraction. And from the aphakic refraction, we can do a vertex adjustment and calculate the K. From the K reading, we can adjust the focal, from the focal length, we can calculate this. And from that, we can calculate the IOL power in the formula by dividing it with the refractive index. We get a rough axial length, and from that, we can do that. So this is another technique which has been described, which can be done. Regarding multifocal IOLs or premier IOLs in pediatric cataract surgery, we need to evaluate the pros and cons. The advantages of multifocal and toric and all are that it has rapid visual rehabilitation and eliminates the need for glasses. But we need to weigh something which is high in vogue in this age group, because the IOL power calculation challenges are there. A proper centration cannot be ensured. Reduced contrast and photic symptoms will result in amblyopia. So we might have to go for a single piece intraocular lenses in most cases, but suppose the visual axis is clear, there is no corneal injury, it's just a blunt injury. In such cases, if we get a proper calculation, we might go in for a toric or a multifocal intraocular lens. So we need to custom make all these things for pediatric traumatic cataracts. Thank you. So I'll be continuing with wrapping up this with the next talk, Dr. Lakshmi.
Dr. Lakshmi will continue with post-ocular trauma follow-up in a child.
So this is just to sum up what we have learned now. We have a lot of terminology systems in trauma. We have the Birmingham eye trauma terminology system, as well as the ocular trauma score. And as Dr. Soumya has already mentioned, the ocular trauma score is a better indicator of outcome, especially in pediatric cases. So why do we need the scoring system? It's mainly for prognosticating these cases, and from a medico-legal perspective, it is mandatory that we score these and document these properly. So the problem with pediatric age group is again the young age, poor visual acuity assessment in the initial phase, and due to poor cooperation. Sometimes we may be able to assess many things when the child is under anesthesia, when we are giving anesthesia for repair. So we might need to score the child according to the examination findings on anesthesia. So documentation is always very, very important in a trauma case. Visual acuity assessment, we need to do some form of visual acuity assessment in the pediatric age group, either a simple fixation following or a Cambridge vision or a Leah symbol. Most of the LCD screens that come with visual acuity have the Leah symbol. So in possible cases, we need to record visual acuity. It gives a lot of information. Corneal injuries, the importance of refraction cannot be stressed more. Most often, we just repair the corneal wound and the follow up may be irregular. We need to counsel the parents that the follow up is very important. And in most cases, it might be a small corneal injury which is away from the visual axis, but still it can induce astigmatism in a growing child. And if this astigmatism is not given and if amblyopia treatment is not initiated, this will not give you a very good outcome. So we need to do a refraction in the postoperative period while the child comes for follow-up, and we need to initiate occlusion therapy or any form of treatment for amblyopia as the age permits. Ocular surface management in chemical injuries is also important because that also might result in a very poor outcome even though the initial phase is very well managed. Aphakic rehabilitation with occlusion therapy, like already mentioned, we might go in for a primary intraocular lens or a secondary intraocular lens according to the prevailing situations. This is of utmost importance, and if you are leaving a child aphakic, the immediate before discharge, it is better to give the child an aphakic glasses for rehabilitation. But unilateral trauma cases, it might be different. In select cases, we might go in for a contact lens, extended wear contact lens, but that needs a lot of expertise. So at least an aphakic glass during the times of occlusion therapy can be initiated in the immediate post-trauma period. Glaucoma, Indian studies have shown that it's approximately 20%. And when should we suspect glaucoma in pediatric ocular trauma? When there is a lens injury, anterior segment inflammation, hyphema, zone 2 injuries, penetrating injuries, angle recession, firecracker injuries, all these conditions we should anticipate glaucoma and evaluate for it. Hyphema, even after resolution, we need to look for rebleed. That is a common cause for glaucoma. IOP more than 21 might need treatment, and they need a lifelong treatment follow-up. Retinal detachment, a thorough posterior segment evaluation is mandatory in almost every post-trauma follow-up visit, or at least a yearly after the child has become stable, because we might miss on peripheral retinal changes following the trauma, and this needs an indirect ophthalmoscopy, and the importance of this cannot be stressed more. Whenever required, don't hesitate for an examination under anesthesia or a mild sedation with a pedicloral in required cases, because if we omit this, this might even cause the vision of the child. So an examination under anesthesia for any retinal changes, if we suspect them, should be done, and this might save the vision of the child. So never hesitate if required, but otherwise try to do everything without an anesthesia. So that is to sum up about the important points in trauma in pediatric. So thank you for your patient listening, and thank you all the panel members and the speakers and the audience for your patient listening. Thank you.
Thank to all the speakers for their nice presentation and keeping to the time. Thank you very much. If there are any questions, it can be answered. If there are no questions, we can conclude the session.
Yes, any questions can be taken now, I think. Sir?
All the topics which has been discussed was highly useful in day-to-day life and practice of ophthalmology. And in corneal, the one which you have been telling that you should not attempt to take the foreign body from the cornea without proper. Probably it could be due to it is going back to the anti-HME. Is it? Use the mic.
You do not know until what extent that foreign body is going, what depth that foreign body is having, and how much of thing. If supposedly it is a child also, you are basically creating a full gap for if you take out the foreign body, plus if there is an infection and if that gap is more, you're not going to handle it in your OPD. So always take the child under anesthesia, then
only,
look for it. Yeah, only
otherwise,
then.
there
Only
is
then.
if it is more than half of the cornea, it may fall into
It may, and then basically your it's already self-sealed there, and that is AC is formed. You can better handle it in OT than when you are doing it in the OPD.
Very good topic discussion. I mean, all the topics are very
Sir,
relevant
any
in
pearls to share, because sir will have an
this was, I
extensive.
have been doing this thing previously. What we have been doing as general ophthalmologist, we used to put an incision at the limbus and put an iris repositor behind and support the foreign body from behind and then take it from the anterior side.
I just wanted to add because I had a similar case, and the DNB resident who was on duty said, "Ma'am, can I just pull it out? It's very tempting for you to pull it out." Patient was not a child; it was an adult. But when we discussed and I looked at it, see, it's always better to make a separate incision and take it out, and because you are going to produce more damage to that incision. And secondly, as she said correctly, you don't know how much it has pierced. Actually, when we looked at when we took the patient to the OT, it was the nail had curved and it had gone behind the lens, and it was almost going behind the. We couldn't find the posterior end very well. So there was, when we removed it, there was vitreous also was coming out. So you may produce more damage if you pull it out. So it's always safer to. I learned that big lesson that day. I was also tempted to do it, but I realized that you have to make a separate. And even though the nail may appear small initially, you may only be seeing the tip of it. So the entire thing may be actually longer than your
actually the
incision.
deeper
And if you make, it's always better to do a separate incision and take it out, because the material may be larger than what you anticipate also, and you'll be more prepared also.
For intraorbital foreign body also, you may feel it is only a small thing, but it may extend very deep inside the orbit. So it's always better to take the patient to the OR and then take it out rather than exploring it in the OPD itself.
A question to Dr. Muralidhar regarding that patient who had that global orbital layer and the global layer, flap tear. How do you make the decision, and how much will you excise it? You said you just excised the global layer and left the patient as such, and the movements improved. So how do you make that decision of?
Yeah, that's, I think, a very good question. What I thought was it could just be a cut and we'll be able to retrieve the proximal end. The ideal thing would be, of course, if you are able to, if you are able to rescue the proximal end, then you can suture the proximal and the distal end, maybe add a non-absorbable suture in between. So the perfect principle would be to restore the anatomical continuity when it is possible. So I did explore, I could not get the proximal end. So the distal end was just hanging out of the wound, and the global layer was completely intact. End to end, it appeared intact for as long as I could explore. There was some fat behind. So what I did was I just closed the tenons over the fat. I could close it with the native tenons that was there in there. And whatever distal end was hanging out of the wound, I simply excised it without resecting it.
There was no movement limitation.
There wasn't any movement limitation. Similar case, I actually planned to publish it, but I found that Raab et al. Had published it in JAPOS just a few, it had just come in the latest issue of JAPOS. Okay. So you just have to excise the global area, the global layer actually it inserts into the orbital pulley, and only a small portion continues anteriorly. So the portion that inserts into the pulley, I guess it was intact because commutativity was maintained. But the portion from the pulley to the insertion, I don't know what function it has really. So that's why I had mentioned, is it a layer to spare? So it was actually acting as a hindrance to depression. So when I excised it, but ideal, this thing would be to restore anatomical continuity whenever it is possible.
Usually you use non-absorbable sutures, sir, for all these avulsed
If I'm
kind
able
of.
to get it, yes, I try using the Ethibond suture that the retina surgeons use.
I have a doubt. Last day, I got a patient with a penetrating injury. It's not a kid, it's an adult. A fine nail was entering. There is a full thickness corneal wound extending up to the iris. It looks like it pierces the iris. But can we get cases like that without any hyphema or significant uveitis? I was looking
Yes,
quiet
it is
and
possible because the rapidity in which the foreign body comes, because sometimes we see just an iris hole and the corneal wound might be, we won't see a significant corneal wound, the iris hole only will be seen. If it's very rapid and very fast, then but maybe one day later you might find uveitis.
Okay, okay. It
But
was 8 hours other
initially,
injury.
immediately, uveitis may not so.
This was piercing the iris, and we can say we will tend to pull it out, but without any hyphema. That was it was touching the iris or extending to the posterior AC was the doubt.
Actually, that patient whom I said, no, the nail, he had 6/9 vision. It was in the upper part. Now 6/9 vision, there was nothing. There was minimal flare in the anterior chamber, but no hyphema, nothing. So that was again, you don't want to create more damage. So that is a reason that. But then, like when we actually took him out in the OT, this nail was actually keeping the cornea intact. So minute we took it out, even though we did another set, we did actually with the keratome, I made a separate section in the limbus, and because when I pulled it, I realized it was much longer than I anticipated. It was like almost like a hook, and then the wound collapsed entirely, and then we had to suture, we had to put glue, BCL, everything, and he has subsequently developed cataract, and then we had to do cataract for him, and then an intraocular lens, everything had to be done. So what you see may be just the tip of the iceberg. So it was not a very, you may get absolutely normal looking eye also.
But in such cases, I think initial documentation and how much the extent is with some imaging modalities.
Yeah,
is
imaging was
very
done.
important
So imaging, CT
document
was
that.
done, and that showed it was going beyond the lens,
Lens.
almost
So-
up to the posterior lens.
So that in that case, maybe we can give an informed consent that these things can happen in the because 6/9 vision postoperatively, this many problems they may not accept it. So any
One more thing I think I would like to add is whenever we have a foreign body, like 2 days back we had an injury. The child had injury 1 week back, and they come 2 days before, and there's full exudates in the endothelium. There is hyphema, and hyphema, because of that we were not able to see. We took the kid to under anesthesia, and that is when we are seeing that there is exudates in the endothelium, hyphema, and there's a hole in the iris. And before that, before taking him, we did a gentle B scan to rule out if vitreous there is an involvement, because that time you have to decide whether you have to give intravitreal also along with that. So that is also very important. So you can do a gentle B scan also to rule out that, and always take an AC tap before you start that case. Before putting any drops, just to take a AC tap, or like how I had showed, take the exudates and send it for culture before putting even betadine, before washing that. Otherwise, you're not going to get any result. Especially in kids, they progress very fast. So you need to send it for the culture and then do all of your operative procedure.
Yeah, rather than a B scan, because in open globe injuries, better don't put a B scan. But in her case, you didn't suspect an open globe injury. Better to do a CT. And one more thing which I've found in traumatic optic neuropathy, though the RTAs were the most common cause, falls were the next most common cause which goes undetected. Fall from height, often the child doesn't complain, and then they notice some squint, and then they come to you, you realize there is a scar here, and retrospectively on asking, there was a fall and child has poor vision. So falls are very underreported. RTAs will be picked up.
Always documentation is very important, and the bystander should be informed about the immediate and later complications.
I had one similar traumatic optic, but not a child, but an adult. She just tripped over her skirt and fell, and she had a very big cut on the forehead. Immediately, she detected vision loss in that eye, and she was given within 2 hours. She was given IV methylprednisolone, but she didn't regain her vision. It was PL negative.
So that Hippocrates
So
sign I find is very useful.
it's very useful.
It's almost
That if
80,
you see an
70%.
injury there, then we need to be cautious.
I think we'll conclude the session. I request Dr. Professor K.V. Raju to hand over the memento and certificate to Dr. Muralidhar.
I would now request Professor C.V. Radha Devi to hand over the memento and certificate to Dr. Vidya. Thank you all. So I think we can proceed to the oration. Yeah, we'll take up speakers. I think the session speakers can take a photograph together.